Hello, and welcome to our first NCD Academy panel discussion on COVID-19 in Asia. As the coronavirus pandemic continues to disrupt our daily lives around the globe, the American College of Cardiology and our partners at the NCD Alliance and the World Heart Federation are bringing together experts from across the healthcare sector to discuss the latest recommendations to keep our patients safe. Today, we will be discussing how clinicians and policy experts are rethinking healthcare delivery to curtail the virus and treat COVID-19 patients in a way that is sustainable and allows us to remain attentive to other critical priorities for the well-being of our communities. I will be your moderator, Dr. Alan Fong. I'm the Vice President of the National Heart Association of Malaysia, Council Member for the Asian Pacific Society of Cardiology, and also ACC's International Governor for its Malaysia chapter. To get us started, it is my pleasure to introduce our panel. First, the Right Honourable Dr. Kui-Hian Sim, who is Minister for Local Government and Housing for Sarawak, Malaysia, and is the past and founding governor of the ACC Malaysia chapter, which, as you know, is the first international chapter of the ACC. And also with us is Dr. Jack Tan, who is the president of the Asian Pacific Society of Cardiology and president of the Singapore Cardiac Society. So to get us started, we will begin with the research roundup. I thought we might spend a few minutes sharing research underway on COVID-19 that may not be relevant to the theme of this panel discussion, but nonetheless has important implications for patients that primary care providers and other clinicians should be aware of. So, Dr. Sim and Dr. Tan, what are the latest findings from any studies underway in your country or our region to better understand the impact of COVID-19 and the viability of potential therapies? Dr. Sim.
Thanks, Alan. Our research are more towards one of the national multi-center clinical trials. But I was spoken to our infectious disease specialist because some of the trials actually we started, but because when our first wave was stopped, so we can hardly recruit our patients. And now with the second wave coming back, maybe we have a second chance. It's really tough for us because all the resources are available. And of course, we are nowhere in terms of tens or thousands of people infected. But of course, we are constantly looking at the trial results, which can change our clinical practice.
Right, I see. Jack, what about you?
So in Singapore, most of our therapeutics trials are like what is happening in Malaysia. They are part of the multi-center endeavors, whether it's on remdesivir, convalescent plasma, or vaccine studies that we're enrolled onto. So we enroll patients for multi-center trials. For the more concrete research, Singapore has a huge medical arm, which currently is pushing out more rapid and faster ways of doing PCR testing within minutes. For example, I think our team in the Lee Kong Chian School of Medicine developed a test kit that does serology very fast, and we have someone from Duke NUS doing PCR very fast on the plating method to get. And for those PCR tests, we're just taking out the mucin out of the equation, just doing the PCR direct to other means. So Singapore is more interested in having tools that help with diagnosis. We don't have much indigenous therapeutic trials. We have studies understanding the prevalence or infectivity for patients, like what's the rate of the virus on Mars, for example, that you have in contact with the COVID-19 patients. So small studies and not quite drug trials at the moment.
Right, thank you. And looking beyond our region, what do you consider to be the most significant recent findings globally in the fight against COVID-19? Jack.
So I think what I found is disappointing that the trial results for therapeutics has not been amazing, whether it's remdesivir or even dexamethasone, because it addresses really the acutely ill. It shortens dwell time, but it's actually not that much better than good standard of care. It means early diagnostic, quarantine, oxygen therapy, early identification of sick cases, vulnerable groups, and early intensive care or ventilation. So those, in my mind, is still the cornerstone of quality COVID-19 care. And I think every country shouldn't neglect delivering good quality care and keep harping on access to expensive current therapies that we have that doesn't really cure patients at the moment, in my mind. I think the research on vaccine does seem promising. Everyone is very hopeful. Again, I'm not too certain when it will come, if it does come, and maybe not so early as well. So over to you.
Yeah, and Dr. Sim, as public health is also part of your remit. So what do you consider the most significant recent findings globally against COVID-19?
I think, I agree with that, because, everybody live in the same state. There's a hopes of quick fix. And what is disappointing is there's actually no quick fix, and you just have to go and take care of your basics. But what I find is in terms of policymakers, in terms of many of us, there's an infodemic. There's so much information, and the worst is there's a lot of fake news. And some of these fake news coming out from the famous Twitter. And the famous Twitter, yesterday I was bombarded by all my colleagues in the policymakers and said that why we are not using hydroxychloroquine? It comes from the US, from the very famous Twitters. And I told them that, look, WHO, the American disease specialists, apart from the top politicians, everybody can say there's no benefits. And they said, no, look at this Donald Trump Jr. Tweeting that we all should give it a try. So this is a challenge for us. Fake news, politicians, because coming out of US, coming out of anywhere.
I see. That remains a real challenge for everybody. And thank you for these valuable insights at the start of this session. Now on to our main topic, which is actually flattening the curve and raising the line. So no two countries share the same experience with COVID-19. Some have faced more severe outbreaks than others. We've seen how different strategies to manage these outbreaks have achieved varying degrees of success. And what works best is also heavily dependent on context. So I'm curious to know what COVID-19 has been like for each of you locally, and the wisdom that you might share after several months of dealing with this unprecedented crisis. So if I start with Dr. Sim, what trends have you noticed in COVID-19 infection rates in your country, or in our country, over the last several weeks, particularly in Sarawak? And what factors have driven these trends based on the data and your observations?
Yeah, thanks, Alan. Sarawak is one of the special regions in Malaysia, but we are not connected to the peninsula. We are sitting on the island of Borneo. So we run our own immigration policy. And when the COVID-19 first emerged, and then in China, when they reached Singapore, Sarawak government very early on stopping all these nationals from Singapore, from China, from coming into Sarawak. And as a result, when Malaysia having first case in middle of February, Sarawak did not have any case until middle of March. And it shows that, if no matter what you have, you must still need to have this immigration policy to stopping people from coming in. Because Sarawak is sitting on the island of Borneo. And since then, the Malaysian government, as part of the national policy, we have what we call movement control orders, in which we basically get locked down between middle of March until middle of May. And the office closed, the school closed, and also only the markets and all those things. And basically open 7 p.m. every night until the next morning 7 a.m. I stay at home. So I never spent so much time in the home in my whole life, you know. So because of all this, it has shown tremendous success in terms of flattening the curve. And recently, since the middle of June until now, relaxation of the movement control orders. And what we noticed is Sarawak, because we had continued to do surveillance, continue to test and test and test, there was a second spike, which is marked the beginning of second waves. And because of all this, we are back to around the town, around the area in which we have more than 40 cases in the last 14 days. We close all the school again, and we survey the surveillance from the market. If there are any positive, we close the market again. We reduce the business hours again. Also severely reduce the number of flights coming into Sarawak. So for Singapore, we used to be a flight every day from Singapore. Now it's 1 flight a week. There are supposed to be about 12 flights a day from Kuala Lumpur to Kuching, and it's going to be reduced to only 3 flights a day. So all these are part of the measures on the in terms of air. But our land borders, which is with Indonesia, since the middle of March until now, we have not opened because the Indonesian side has a population of about 20 million. Sarawak only has a population of 3 million. And we just find that even we just need to protect our population. The good things about this and the bad thing about this is this. The good thing is we were very successful flattening the curve the first way, in which we lost only about 17 patients, and we had about 400 plus Sarawakian out of 3 million infected. We running about 3 per 100,000 people infected. But then the bad thing is when the second wave comes, we have totally had no herd immunities, and we are back to starting all over again in terms of like beginning or middle of March. And these are the challenges to convince the people in Sarawak we need to do this suffering and also inconveniences again. It's quite a challenge.
Yes, indeed, especially as Sarawak has such a large land area, over 100,000 square kilometers, and about 3 million population. What about in Singapore, which has double the population in a very small, densely populated island? Now, Jack, what have you noticed in these COVID infection rates? How have the clinicians and health officials improved public compliance and with social distancing and recommendations to reduce the spread of COVID-19?
Thanks, Alan. Maybe I just share one slide and speak to that about experience in Singapore. Are you able to see the slide?
Yes.
So I think this slide was shared to me by Liu Haobang from Sabah, actually. So I think it's a public health slide. So I really like this slide, and it shows the health footprint of the pandemic, any pandemic, across a time horizon. I think the first wave always hits when it impacts mortality and mobility because people are swamped and overwhelmed. So the observation about this part in Asia, in my mind, is that a lot of Asian countries were hit by SARS-1. So a lot of us had the scarring experience of SARS-1. We were a lot better prepared and knew roughly what to do for SARS COVID-19. So I think there was an impact, but it's not as great as those countries that didn't have SARS. So I think that allows us some learning experience. Then you see the second wave, where because of the impact of resources and restriction on non-urgent COVID conditions, predominantly your STEMIs, ACS, cancer therapy, there was an impact on resource and treatment. And then the third wave, the interruption of NCD and chronic conditions like diabetes, hypertension, non-communicable diseases like cancer, COPD. And I think we are 6 months down in Asia, approaching and merging the third and fourth wave, which is the psychological stress, trauma, economic, and psychiatric burnout. A lot of patients, industry, doctors, healthcare physicians are facing. So I think, and of course, too much burnout from webinars. Forgot to say that. But a few things that I want to point out is that I think the third wave or the collateral damage in cardiology is something that us as a cardiological professional societies, whether it's ACC, WHF, should come out and rightfully lobby and pitch so that this collateral damage is not as impacted as it has been. So I think the access to care, access to information, screening, treatment, education, research activity for cardiovascular care, non-communicable disease care shouldn't be interrupted, and it's the ownership of professional societies to lobby and pitch for that. I just like to then bring us back to what is the Singapore experience. I think what I've learned from observing what Singapore government has done is this joke. So in December, I think my boss, Aaron, you know him, complained to me and said that Singapore's waste so much money. We have a 300-bedded hospital that's empty. It's called a National Communicable Disease Hospital. So it's empty. It's open in September 2019. It's completely empty. And by February of 2020, it's almost packed full of COVID-19 patients. So I think this is 16 years after SARS, and one observation is that you cannot wait for the problem to come before you answer to it. I think there's a lot of pre-planning, whether it's how you deliver NCD care, planning for a pandemic. You can't wait for the pandemic to come and then try to find a resource for it. And the other thing that Singapore has done is, I think they have been very, very transparent. The sharing information, the curtailing of fake news. And because I think nothing kills faster than fear itself, really. I remember early in the COVID-19, when there was a patient who was stemming, came to my hospital, the first hospital to get a COVID case. He refused to get acute PCI. He said, I don't want to go to a COVID hospital. and then he discharged against advice. He took a taxi to another hospital which didn't have COVID at the time, and he collapsed and dropped and had severe brain damage. He was 40-ish. So I think fear is a real killer, and governments who do not address the issue honestly and transparently will encourage fear. And I think one thing that Singapore learned early on is to adjust again and again. So early on, Singapore said don't need to wear masks. The evidence suggests that masks, we need to preserve for a healthcare worker. There's not much need. Then we found that they are asymptomatic spreaders. So we say everyone mask. Now you don't wear masks, you get fined $300, more than if you buy chewing gum in Singapore, for example. So I think we need to be flexible in adjusting to onslaught of data. The other thing we learned in a very painful way is the vulnerable groups among our society. I think COVID-19 is a very smart virus. It really points out all your weak points. Your underprivileged folks, your communal living folks, your not so well taken care elderly, your patients with poor access to care, medical, financial. So it picks out all these people that kill actually, and infect. And it's a reflection of how well you adapt to it. So in Singapore, our community living groups like our dormitory, transitory worker group had a huge blowout. So we were struggling to cope with that. One thing I felt was good was that the other big community living group in Singapore is a nursing home group. So I was very afraid that what happened in the dormitory can happen in the nursing home. But I think because the issue was addressed very fast after seeing what happened in the dorm, we never had the mortality. So I think we're close to maybe 50,000 now, maybe 25 deaths. So our death rate is probably one of the lowest in the world, like 0.05 or 3% death rate. But it's still a painful lesson, I think. And we are still waiting post Singapore election, whether there's a second or third wave. But let me put it this way. I think Singapore early on has gone on to the strategy to say that we want to flatten the curve. And that's our strategy, not a strategy of allowing everyone to be infected and herd immunity. So we recognize that the schematic will be spike, control, spike, control, spike, control. So we are mentally prepared for research, control it, research, control it, but at a great smaller scale, so you can prevent deaths. And also we can wait for new therapies like vaccine to come upon us. So I think these are some of the strategies that Singapore has tried to enforce. to flatten the curve. The primary aim actually is to reduce mortality, I think, at the end of the day. And also it allows us to reflect on how we can do better for our vulnerable groups or patients. I think that's also very important. But I think we need politicians like Professor Sim to really lead the fray, because it is a public health thing. So individual doctors have very limited control. We need politicians, we need government efforts to coordinate, convince, to message, and to lead us really. So we need tons of leadership. Back to you, Alan.
Yeah, I mean, this is very relevant in this age, at this period of time in this COVID pandemic, especially in this semi-lull period. And I think one of the fundamental areas that has been looked at very closely is the screening and contact tracing, which are widely considered as a gold standard for avoiding large spikes of virus outbreaks, like you mentioned. So if I may start by asking Dr. Sim, how can these health systems like ours, successfully expand these areas in rural and urban communities in the ways that can recognize the differences in resource availability and population density? Because ours is we have a large disparity in terms of the rural and urban access of care.
Thanks, Alan. I think it's really interesting because 6% of the population live in urban area, where we have 44% living in rural areas in the deep jungle of Borneo. And then it's quite interesting that at the very beginning we fully aware of that, and because our resources, medical resources, will not be able to cope if the virus spread into the jungles and all those things. We don't have good tertiary hospital in those areas. And so at the very beginning, we're making sure that the movement control, no one allowed to go to those areas. We block the roads, we block the rivers, we block the air transports, so that so as a result, throughout these 4.5 months, 5 months, the jungle area of Sarawak remains green. Despite that, we do surveillance. And basically, this is only possible with the help of local people, and they will put out signs that say outsiders are not welcome, in the long houses. So they said, if you want to leave us anything, you live outside our jungles. And so that is on the rural area. As a result, about 70 to 80% of Sarawak in these 4.5 to 5 months, not a single case. The cases all evolve in around the urban area, the 56% of Sarawak. And it also shows us that this COVID-19, we all learn from each other. There are so many things that we need to learn, but the only message that I always tell my colleagues, political colleagues, leadership, is that number one, we have to react fast. Number two, you have to base on science. This is not so much based on economic. Economic, like Jack said, is phase fourth way. At this point in time, is science. So as a result, we make use of this period of time. We know that we need to do testing, and tracing, and treatment. During this period of time, we build up the capacity to do testing for a few hundreds a day to a few thousands a day, which and move beyond just one location in the capital city of Kuching, but to other cities like Cebu, Bintulu, and Miri. And in this period of time, we're able to do that because wherever there are resources, we just pull them. We pull them from veterinary science, the PCR machine from veterinary science. We pull them from forestry department. We pull them for university. We pull them wherever we can get our hands on. And then not only just the equipment, all the scientists, all the lab works, we pull them and we train them out. So even though now the second wave is coming back, we are much better prepared than the first one. So in terms of testing, in terms of also equipments in the hospital, during this period of time, we also built up quite a lot of the ICU beds, ICU ventilators, and the pumps and all those things. So it's a lot of government expenditures, but we realize that life is not measured by just money, and so that's why we do a lot of all those. After the first wave, we start to learn, are we going to get shortage of PPE again? And the first wave, we had to fly, we had to charter the A330 wide-body jet and to fly all the PPEs from China. And the whole world is grabbing for it. Normally, it's cash on delivery. And during the period of time, it's cash before delivery. And so we start looking at the PPE now. In the second wave, we start looking at the testing reagents. We start looking at all those. But one of the hardest thing is policy, like what Jack said, to build enough capacity that if nothing happens, the public is going to say white elephant. Or are you going to be so visionary? Anything happens, this require a bit of statistics, a bit of looking at data, a bit of courage, and judgment to all these resources at the same time, making sure your other policies to make sure that the number of cases doesn't need to spike so much that use up all your other resources.
Wow, that's very enlightening, very interesting take on this particular aspect of management and at a public health and policy level. What about in Singapore, Jack? I mean, in terms of the screening and contact tracing component to limit the outbreaks, particularly in confined spaces and communal groups.
So thanks, Alan. I think the experience in Singapore probably can only be applied to city-states that are equivalent. So it's not necessarily translatable to Sarawak in the deep jungles, for example. We barely have a patch of jungle, so I can't tell you that much more. Maybe a few observations coming from Singapore. Firstly, policy at the government level was driven not from Ministry of Health. It was all government approach. So the task force that was addressing COVID-19 consisted Minister of Education, Foreign Affairs, Trade, Health. So all these guys and manpower. So all these guys came together to say it's a whole government approach to address all facets of this issue. Because I think I say lives first, but actually people's livelihood matters to a lot of people. So I think the government doled out tons of money. Looks like too much. It didn't reach my pockets, but it's a lot to everyone. And I think trying to show that there was a whole government approach to help with people's livelihood did help. In terms of testing, I think we ramp up very early on our testing capabilities across the board in Singapore. So we got this biomedical hub, we did that. One interesting approach is to be creative. Maybe I share one tip that A-Star proposed, which worked quite well. So it's called batch testing. As you know, early on, ELISA PCR test kit went down and Singapore was running low. So for a group of people who we think the probability of positivity is low, so we test 5 of them into one PCR kit. And if the PCR test is negative, all 5 are clear. So we conserve PCR kits in that way. So we can increase our capacity from maybe 8,000 runs a day to 24,000, for example, in a shorter period of time, especially for the vulnerable groups. So I agree that testing is important, especially for screening, contact, as well as fairly asymptomatic or mildly symptomatic cases. But I think testing is not the be-all and end-all of it. I think it's very important to focus on individual responsibility, keeping to social distancing, masking, personal hygiene, and also practices that encourages that, whether it's at the next level, your employers or the society, and I think all this helps. And of course, at the government level, policies and laws to enforce that. So I think it's the practices more than the testing per se that flattens the curve. And in regards to resources, I think in Singapore, what we realize is that we did plan for pandemics, but there's never enough ventilator if we're going to swarm the system, no matter how you do it. I think 2 days ago, KK Hospital, one of the anesthetists came out with a new ventilator invented and manufactured in Singapore. to deliver ventilators that we can build ourselves rather than try to buy from all the makers. So I think we do get all these things coming in, but I would think the hardware, in my mind, is less important than the software as usual, right? So I think the software is how, as a people, we react to the virus, how responsible we are. And I would pitch it back to the professional societies like ACC or WHF in addressing as lead societies fake news that's out there. I think we really need to come out strongly to address fake news, either for therapy, prevention, or fatality. I think all these things are great. I think we see the erosion of leading bodies at WHO, which is bad for us as a fraternity. So I think we need lead societies at ACC to really also lead the front in voicing out more strongly. Although I say that casually, but I'm not in America. I think it's not so easy to voice out against your political leaders, but I think we need to try when you see wrong. Thanks, Alan.
Yeah, I think you brought a very pertinent point that is, I think, common among some countries in Asia, like Singapore and Malaysia, which tend to adopt an all-government approach in the management of COVID-19. One of the issues that we had in the pandemic is the accommodation of the admission of patients for care. And how in Singapore would you able to accommodate all the COVID-19 patients to be looked after, and what protocols have you put in place to triage these patients for inpatient treatment?
So I think Singapore went through a few phases for this. I think when the numbers were low, we admitted and treated all these cases in the hospital, and we are constantly evolving. And initially, we only discharged this group when the PCR swab test turned negative. So some of these long-term shedders never turn negative, even after 30, 40, 80 days. So they are forever with us. And subsequently, we devised many layers of care. For the sick, they go to the hospital. None of these cases are triaged safe enough to be at home. So they are placed in community care facilities, step-down care, they are in hotels, quarantine, they are in resort that's dedicated for COVID-19 military camps. Even our Singapore Exposition Hall is turned into COVID-19 segregation halls for COVID-19 positive patients. And our SIA Singapore Airline hostesses and stewardess, they are not flying now. A lot of them are redeployed to the hospital to be our nursing staff as well. So in this period, so I think this approach allows us to really, in one end, take care of them when they are infected. The other one is to effectively quarantine this group of infected patients and not spread further.
That's right. I think similarly in Malaysia and many of the developing countries, we also do this admission of all COVID-19 positive patients. So if Dr. Sim, you can clarify, explain how is it done here in Sarawak and Malaysia in terms of accommodation of all these patients, and how do we triage these patients for inpatient care?
I think, first of all, like I'd like to echo what Jack is saying. No matter how much we have in terms of hospital, unless the public, do their part. Otherwise, we will be chasing our tails. And I think the single measure that which is more successful for us is, let's say, a lockdown. Everybody stay at home. Everybody stay at home. That is a single most important measures. But on the other hand, you cannot stay at home forever. And at some stage, you need the reopening. So we used to say either, and our public used to tell us that either die of virus or you die of economics. There are a lot of opportunity to come if you can pull through this. So the new norms, the new norms and the policy changes, is evolving. As I said, none of us has experienced COVID-19. We learn from each other. We look at other countries, what to do and what not to do. And most important thing I find that is at the very beginning, in every town, we identify one hospital as COVID-19 hospital. So if you are SARIS, if you are if you have influenza like illness and all those things, you all go to that hospital. Then the other hospital, including a private hospital, will take over all the other cases, such as the routine angioplasty, the appendix, and so on. It all go to other hospital. And so there is a good cooperation between the private hospital and the public hospital as part of national duty to help each other. And I want to thank all of them for that understanding, instead of arguing about money and so on. But having the COVID-19 hospitals, you find that, we need to redeploy a lot of resources. We pull nurses coming in, and they, instead of 3 shifts a day, they do 2 shifts a day, and 7 days on, 7 days off. So, and these nurses, a lot of them way to logistically house them somewhere instead of letting them go home. So all this involving in a lot of extra costs and sacrifices and inconveniences to everybody. But I must thank everybody, because we are very believe that unless Sarawak and everybody come together, we cannot overcome this COVID-19 pandemic, because it affected everybody. But the greatest part is the greatest success. I must thank the public, who really will self-discipline, sacrifices, and also empower reporting through our hotlines for people who are not follow the new norms. And then I always said that our enforcement can only do so much. You cannot jail so many people. You cannot jail the whole citizens. We don't have a national federal agents to come to our rescues. And we just have to convince everybody that this is for yourself, for your family, for the sake of the community, for everybody, that we must do this. And this one is one of the hardest job for us as in politics, is to convince the masses that you must do this for yourself, and not because we want to put you in jail, not because we want to fine you, not because we want your money, because we want you to be alive. So at one stage, the hospital also faced a lot of troubles, because a lot of the junior doctors, everybody is scrambling for PPE. Everybody want N95, despite there's a clear guideline who should use N95. And then we don't have enough N95 around at one stage. So it's to convince them, to tell them why, if you are not in contact with COVID-19, you are at low risk. Why we want to prioritize the resources to those people. So that is quite a challenging task for the hospital directors, for the politicians, to convince them that this is what we need to do. We also see the bad things and ugly things, but I think that's human. It allows us to be more focused and to know actually where to go from here, and how to get ready for a second wave, how to get ready for a third wave.
Yeah, I think you really described it very well in terms of the population discipline. I think this has helped greatly in the curtailing the COVID-19 spread. I think particularly in a situation where we have a very diverse population in a large rural urban type distribution. Can you share with us your experience in what Sarawak has done using telemedicine and using remote monitoring to look after and to ensure the patients reduce the potential spread of this condition?
Yeah, telemedicine, is one of the things that we think eventually will be the thing for Sarawak. The population is very sparsely populated, a very big landmass. But sometimes our bigger challenge is still trying to get connectivities to all these deep jungles, and the telcos are not interested, because the number of population over there is so small, so they don't have much money to make in terms of big investment. But having said that, I think the handphone is working wonders to everybody. At least even in some very deep jungle, you still have access to handphones, and you still be able to Facebook. You still be able to face all sorts of allow us to solve, to help them with all sorts of queries, all sorts of chronic diseases that we need to address. But in terms of managing COVID-19, fortunately, that most of these things, 90% of COVID-19 happens in the capital city, which is Kuching. And so Kuching houses about a third of the whole state population. And that's why we for Kuching, the bigger challenge is not so much of telemedicine. The bigger challenge is how to empower those doctors in private, the general practitioner in private, to do more in terms of helping us to identify salaries, to pick them up, the community surveillance, and so on. And the issue with this is because it's not just having those mobile equipments, having extra tools, but one of the issues is the legislations and the payment. In Sarawak, in Malaysia, if you don't, we don't have basically a make pay you on telemedicine, and so as a result, we still end up having a lot of face-to-face in terms of seeing patients. But I must thank the hospital for everybody taking initiative, that especially those with chronic patients, chronic diseases like diabetes and so on. They continue to get their medications through the drive-through, through the express pause. So instead of all coming to the hospital and to get medication, all this helps a lot. At the same time, they can send their personal information in terms of blood pressure, in terms of their blood sugars and all those things to the relevant sections of the hospital, so that in case any adjustments and so on. But I think in terms of what Jack said is correct. Even when we don't do this, I think a lot of patients are very wary of COVID-19 hospital. The minute that you say you COVID-19, I think even our heart center, the number of people having heart attack drops. I don't know where they are. Suddenly they just disappear. Normally everybody are chasing you and say, how come the elective takes so long? 3 weeks. I want elective tomorrow. But during this COVID-19 time, they're just so quiet. Stay at home, no more angina, no more heart failure. So I don't know what's happening.
That's very interesting. I think going over to Jack, and if I can ask you, in like a very well developed and well connected city like Singapore, the impact of how did you leverage on the telemedicine and the IT in terms to help patients and track patients in your community?
So, okay, maybe I just share my 5 cents worth. I'm not a telemedicine expert. Even before, so maybe I share on the silver lining side. I think before COVID-19, you see the policy makers are very wary of telemedicine, potential lawsuit legalities and all this. But once COVID-19 came, I think telemedicine seems a good idea now. So we could do more telemedicine. And just so happens, I think the ministry was already looking at it. There was 2 licenses given out for telehealth consulting in Singapore, one of which was founded by my colleague Natalie, which you met. And they provided telemedicine. They have a model of care. And when COVID-19 came, there was a huge number of NCD type care facility. Like I started doing telemedicine care for my cardiology patients early on. And very early on, because Singapore has already gone on to full EMR, electronic medical records, so it's much easier to deliver medicine to them. So they did not come. They just need to say, prescription running out, we repeat prescription is delivered. And it's free of charge for patients, the delivery service. So I think we already had the system in the city state where there's easy access. It was EMR in a sense. I think for telemedicine, we are still trudging along. We started recruiting some patients for it, and we're truncated maybe at best 5-10% of patients to telemedicine. The real barrier is mindset and cultural changes, I think. Not so much technology. Even in Singapore, everyone has a smartphone, great connectivity, broadband. But the mindset is probably in the deep dark jungles in terms of that. Everyone wants to see their sensei, their doctors. Sometimes you tell them to see my nurse practitioner, also don't want. They want to see the doctor, So I think there's, but COVID-19 is again an opportunity because for once they don't need to come and see you. They say, okay, I call you on the phone enough, I take the medicine, donate, and they are doing fairly decent. So I think it's an opportunity also for a few things in my mind for telemedicine. So in my own personal view, it's an opportunity for countries where maybe it's not so connected to leapfrog countries which are already invested in resources in huge hospitals, polyclinics. I mean, your government is invested, is beholden to government to make use of facilities now, right? But in countries where you didn't have, why don't you invest more in how your healthcare is more front-facing, more on demand? Because what patient want is not, how we do clinics, right? I do clinic because I'm free in that slot. You can't see me in that slot. It's not when you're free, it's when I'm free. So I think for telemedicine to work, it should be an Uber type on-demand service. We, as healthcare, we need to look at how do we present on-demand care, improve concrete outcome rather than do more procedures or more consults. And I think a lot of the consults that we do actually can function on the telemedicine if patients can also adopt to the mindset change. Connectivity and access and quality of care is one big issue. It's not a new issue, and it's different across different Asian countries. So in countries that already have a very well-developed healthcare system, easy and cheap access to care like Malaysia, it may be easier. But in countries where medicine is not free, consult is not free, I think it's not so easy to translate to the next level of care. So I think Malaysia has a great starting ground. I think the next level of care or transition may not be so hard as you may imagine. I think we always talk about barriers, but I would say let's use this as an opportunity in how to leapfrog the next model of care, to bring care to front-facing, community, personalized, responsible care. Don't come to the hospital. I think it's a good thing they're not coming to the hospital. I'm not sure whether they're dying or not, but don't come to the hospital. I think if we can translate that to effective outcomes, I think we have a winner there. I think we can try.
Yeah, you're right. I think it resonates very well, not only in developed countries, but also developing countries where going to a hospital may involve traveling long distances. I think the potential of using telemedicine could change the way we manage particularly chronic disease. And talking about medicines, since both of you are heavily involved in clinical trials all your careers, we are now in the era of looking at vaccine therapies for COVID-19 rather than just the therapeutic component. As you know, there are over 100 vaccine candidates in development at present. Now, if I may start with Jack and ask Jack, from a clinical standpoint, what do you think is your choice of a vaccine strategy in your area of practice? And then how would you prioritize those to be given the vaccines when it becomes available?
I think it's great that so many people are interested in developing a vaccine, but I would like to put a word of caution there in my own personal opinion. I think vaccines cannot be rushed, and it needs to be proven to be effective. I think we've seen how touted COVID-19 therapies have fallen by the wayside once it's put to the test. So I think an effective vaccine needs to be proven as well. And in the rush to get it out to market, I'm not certain. So, but if we do have an effective vaccine, let's say, and the vaccine also may be seasonally re-administered, I think one approach could be healthcare workers first, because they are front-facing and treating COVID-19 patients, and then extending out to the vulnerable groups. Ultimately, for a vaccine to be effective, as you know, it needs to really hit at least 40% of the herd to get herd immunity, combining with the previous recovered COVID-19 patients. So I think for it to be effective, we need broad access, not just to healthcare workers, to vulnerable group, to the guy driving you in the bus to the guy serving you the soybean drink. So I think if you want to bring the vaccine to town, you need to consider that the vaccine needs to be given broadly to your population, and the ability as a country to do that. You know, I think you're not going to have the herd immunity for vaccines to be effective. I think that's my own take.
Yeah, thank you very much. And Dr. Sim, on your wearing a policy hat, I think is a more challenging thing in these circumstances. What do you think is the best vaccine strategy or your preferred vaccine strategy for COVID-19 when it becomes available?
I think the public has, the public and a lot of the politicians all trying to have a quick solution. Quick, any vaccines, to many of the lay people, any vaccines will do, and because they're all sick of having the new norms, having the social distancing, having the face masks, having the hand sanitizers, and not allowed to be in the pub and not allowed to be in the karaoke and all those things. I share with Jack's cautions. If you look at HIV, they've been trying to develop vaccines for the last 30, 40 years with tons of money being poured in. We're still yet to get a vaccines. Why I mention HIV is because HIV comes from animals. The virus comes from animals. And this one, COVID-19, also comes from animals. So to eventually, hopefully, that we will have a vaccine. But even in the vaccine, right, the priority is to all the frontliners. To the frontliners, including the hospital, the nurses, and to me, the frontliners also including those like the police forces and the army, which after our jungles, our borders in the jungles, because often I'm so worried about for them is because if they get infected, right, the whole army camp will get infected, and similarly, like our recent outbreak in a mental institutions, and then we had to lock everybody down for about 1,000 people, and that is looking like going to be our biggest cluster. To have vaccines, you have to be quite effective, which is quite a challenge, because vaccines can also give people a false hopes that they feel that they are safe, but in fact, the vaccine may actually only running about 80% safe. I'm very sure at this point in time, if you have a vaccine which can give you 80% effectiveness, right, everybody will grab that now. But then the 20% still will be spreading the disease, which is quite a large number. It's a challenge, but the people's behavior, understanding the disease, and everybody buying it and doing all what is the new norms is so important. And I think it's important not only for COVID-19, because I'm very sure after SARS, we learned a fair bit. After COVID, we learned a lot more. And there are a whole lot of other viruses will be out there, Ebola, and MERS, and all those things. They were constantly emerging. So I think that every time this thing happens, it gives us more and more experience. The policymakers also will be looking at it and passing more and more laws and public health measures. But eventually, the people has to understand that there is no quick fix. There is no quick vaccines. And even after COVID-19, there are other viruses going to come around, and then they will inflict maybe not just very infectious. Not only the R naught is about 1.5 to 3, but it may have something which has extremely high mortality, and then we will face another crisis.
Yeah, I think this is marvelous. I think it's great discussion, particularly the condition where, like most of these microorganisms, the COVID-19 can also evolve, and they evolve quickly. Just that we have to evolve quicker. Jack, you'd like to say a word?
Actually, I think you do more trials than me, so I'd like to hear your opinion about where you pitch the vaccines at, actually, Alan. I'd like to hear your opinion.
Yeah, for us, I think I'll take the same position as yourself and Dr. Sim. Not because I consider you both my mentors and my colleague, but I think getting it to those at the real front line would be the priority, and that would be where I would pitch it first. Second will be those that are in the vulnerable groups that who are likely to spread very, very quickly. And especially in the context of if you're opening up schools, we have to take that into consideration as well. It is probably easier to control teenagers who are better informed, but if you have young children in primary schools, they are a classic vector for this very clever virus. Yeah, who tends to spread amongst young children and not giving them many symptoms. So I think it's in the context of the vaccine story, that's where my betting order will lie. I don't know. What do you think, Dr. Sim?
Yeah, I think so. In terms of, what Jack is trying to get is, vaccine do you think will be coming through? I think, at the moment it's too early for us to say, because this is a virus which is less than 1 year old. And there's constantly new things being learned, and this virus on the first wave, we see that there is a lot of severe cases in terms of required hospitalizations. Now in the second, in the first wave, we only have 50% people have asymptomatic. In the second wave, we find that we have about 80% now asymptomatic, and then the population are getting younger. Asymptomatic younger, and then the symptoms, some of the so-called asymptomatics, right? You look at, you start wondering, is that really the symptoms or not? Some better known one will be like loss of taste, migraines, headaches, But now it's an evolving virus. So it looks like even if we had discovered a vaccine, it will be a bit like flu. Every year, you need to tweak a bit. If you don't tweak a bit, right, this virus will outrun you, and your vaccines will be useless. So this will be enormous challenging, and to do that, the multi-pronged is still going back to the people, behaviors, building up the resources, or testing, treatments, all the other infrastructures that we can do to help us to not just treat patient better, pass information to the people better, and to also how to track people without infringing on their privacy too much.
Well, yes, I think these are all, as we evolve as a human race and the clinical professionals, we take these all into consideration. But the hardest decisions have to be done at policy level. And we're really grateful that you are here and from the public health and policy perspective to give us a different take on this point. So I think with time running out, I'd like to close this session. And it has been a really informative session for me. And hopefully it is for all of you as well. So a big thank you to both our panelists and viewers for the time to join. And I hope you can tune in for our next regional discussion coming soon, where we'll go into much detail on the major disruptions to standard NCD services caused by coronavirus, their consequences, and mitigating strategies that we can follow as healthcare providers. So with that, on behalf of the ACC, the NCD Alliance, the World Heart Federation, I'd like to thank all of you for participating. Thank you very much.
Thank you. Stay safe.
Thank you. That's great. Nice to see everyone. Keep safe.
Yeah. Bye-bye.
Bye.